Good afternoon. We're here for the mayor's budget hearing with the Hospital Authority this afternoon. And I'm joined by the Finance Director, Talia Lomax O'Neill, and the city's Chief Strategy Officer, Brian Kelsey. I see Council Lady Taneka Vircher, who's the Chair of the Budget and Finance Committee, has joined us, as well as Vice Mayor Sherry Weiner. I can see you there as well. I guess that I don't see any other council members at this point. Before we get started, I've been giving a little snippet here at the beginning just to make sure everybody is aware that although we had significant revenue increases in the past 2 years of more than $200 million, it's not likely we'll have that much this year. So in preparation for that, we've asked departments and agencies to come essentially with a status quo budget request. That way we can stay within our current revenues and a historically low tax rate and still provide the same level of service to the community. And I know there'll be some exceptions to that, but that's the general guidelines that we're operating under. Having said that, Dr. Webb, if you would introduce yourself and your group today, and then we'd be glad to hear from you, and we'll have some questions at the end. I'm pretty confident. Today.
Thank you, and good afternoon, Mayor, and to your staff.
Thank you.
I'm Joe Webb. I'm the Chief Executive Officer at Nashville General Hospital. To my right is our Chief Financial Officer, Mr. Bruce Naramore. To my left is our Board Chair, Dr. Jan Brandis. And I'm going to open up with Dr. Brandis, and then I'll follow.
Thank you. We appreciate the opportunity to be here, and I would like to say that it has been an extraordinary experience for us during a very challenging fiscal year. We now have had this recent supplemental funding that's been provided through Metro Council. That really comes on the heels of Mayor Briley, your initiative about resetting the overall path that General has been on, and also with your commitment to inpatient funding and to really changing the focus of how we move forward. We also were very grateful for the show of community to support in the recent Vanderbilt poll, which showed that this community is committed to a safety net hospital, and in particular to the Index Hospital, Safety Net Hospital, as our collaboration with Meharry really shows. So in terms of the programs that we are most proud of, I would say that Our Kids is one that has received continuous national recognition. I think it's a program that is unique and provides continual help for patients and their families. It also, and I think our director, Sue Fort White, is here today, our oncology service, which is done in a collaborative sense with Meharry and with Vanderbilt, has silver status. We also have received recognition for our patient-centered medical home, which is really another way of managing populations of patients in a way that allows them to really have a home, to take care of them, and to look not only at their medical needs, but to look at how, from a sociological standpoint, those patients can receive care and receive it more effectively and at a lower cost. In addition, we're very pleased, though we are not at the status where we need to be, or not at the level where we need to be, with the Metro Incentive Program for Metro employees, which allows Metro employees to use our services, our physicians, and our programs without co-payments. So again, that's a place where we hope to be able to give back to the city, in addition to the way in which we often are collaborating in taking care of our prison population and in other patients who are underserved, both either through coming from federally qualified health centers, from other programs, and then certainly we also have our base of loyal patients who do have existing insurance. So with those things in mind, we, of course, are in a slightly different position, though we certainly recognize the status quo budget. In reality, we now are sort of counting our status quo budget as a budget proposal that includes the monies that we were given last May, plus the monies that it has taken to run. Again, with some of the changes that happened over the past year, our numbers do not reflect what we anticipate they will in the future. But we've tried to be very conservative in this budget, and I think both Dr. Webb and Mr. Naramore will elaborate on that further. I would say that we are very grateful for our ability to participate in the reset process. We also have representation on the Metro Council stakeholder group, which we're grateful for, that Vice Mayor Wiener has put in place, and we're also participating in the shareholder group or stakeholder group that Dr. Hildreth, our Meharry president, has also initiated, and we're grateful to him and to Dean Mallett for being here today. So we have, I think we're in a place that we have not been in the past in terms of really trying to unite Meharry, the stakeholders in the city, in terms of both you, Mayor Briley, and the council, our partner Meharry, and really at looking at a unanimous process as we move forward. That doesn't mean it will always be perfect in terms of how we go about it, but we really are committed to that process. And we, this Monday, I think we have real unanimity from our board about this budget, and we recognize that it's not entirely in alignment with the status quo. So, Mayor Briley, I appreciate your comment about you recognize that there may be some exceptions. In addition, we now are in the process of trying to move forward with other collaborative programs to try to see what other resources we can marshal to help initiate newer programs that will not necessarily be covered in this budget. So with that in mind, I'll turn it over. And again, we're very grateful to the support that Ms. O'Neill, Metro Finance has been meeting with us weekly for a period of some time, and Mr. Kelsey, we're grateful that you are now attending our meetings and have made your services available. So thank you.
And of course, we do appreciate the support of the mayor as well as the city council for the hospital. We are excited about working with this administration. And our mission to provide health care to the underserved is certainly critical to the citizens of Nashville. A health care delivery model that we are currently utilizing and have put in place is achieving excellent outcomes for the population of patients that we serve. We've received the highest level of recognition from the National Committee for Quality Assurance through our patient-centered medical homes. We also, as Dr. Brandis alluded to, in our triennial accreditation survey for our cancer care program, received 5 out of 7 commendations, and the silver level. That program's been in place for 76 years. And my understanding is that this is the first time, I wasn't around when it started, but my understanding is that this is the first time it's achieved the silver level recognition, and gold is the next goal for us. A couple of other positive accomplishments that we've made. Our census is starting to grow back, and so we're pleased with that. Staff morale is high. Our relationship with SEIU, the union, is excellent, and we're certainly working very well with our partners, Meharry, to deal with some of our challenges with growing our volume and other areas of the hospital, as well as the medical staff. We've achieved the triple aim of health, which is a national initiative put forth by the Institute of Health Improvement, and that is to improve patient outcomes, which we've demonstrated, improve patient experience, and improve on cost per capita, the population that we serve, reducing that cost. This is a hospital that we believe that Nashvillians can certainly be proud of, and this is a big year for us. This year we will be undergoing, for my tenure, the second triennial Joint Commission survey. The opportunity is already there. They could come in any day and up through October. So we're in in full form of preparation for the upcoming Joint Commission survey. Now, our budget, which we will now get into, will reflect an accurate accounting of our operating needs for 2019, and they'll be based on these will be based on historical trends, some of the better historical data that we've had because we've been able to compile that over the last 3 years, particularly. So it'll be data-based projections as well as cost control initiatives that will be included as a part of our budget presentation today. Mr. Naramore, our CFO, will go into the budget now.
Excuse me. Thank you for your time today. I just want to walk through quickly for the group some of the assumptions because a budget is as good or as accurate as we start our starting point with assumptions. So, we had a significant drop in census with the announcement in November. This last month, really, we've started to see our volume sort of pick up again because when we put this budget together, I was seeing nothing but decline, and so I'm thankful that maybe I'm not that far out on the limb projecting a 12% increase in inpatient admissions next year compared to our current year. So we're estimating, a 35 average daily census, true inpatient average daily census, versus prior year was about 42. One thing in the hospital business is we drop our average length of stay. It's dropped about 10% over the last 2 years. So for the number of patient days that I have, same number of admissions, my average census is going to drop 10% because I'm dropping my length of stay. So those patients are staying in the hospital for shorter periods of time. That's a measure of quality in a hospital. You don't want people in the hospital if they're not sick anymore because there's a chance for them to get an infection or to get sick. So we try to move them through the system. Obviously, with Meharry's help, that's what we do. So in most hospitals, you're seeing a declining length of stay. You're seeing admissions relatively flat, slightly increasing across the country. We're projecting a nice increase next year for 2019 budget with, thankfully, a little bit more stability in the future outlook for the hospital, support from administration, certainly support from the council. In your packet, I know you've seen them in our prior meeting, but we just have some sort of 3-year graphs that give you sort of a history of admissions at the hospital. You can see they've been on a small decline, but they really dropped off significantly November, December, January of this year, and February as well was very low. Dr. Webb alluded to it. We saw a significant increase in the first 2.5 weeks of March. We've seen our bed occupancy up in the mid to high 50s, a couple of days at 60, and that's probably where we were back in July timeframe when I first arrived here. We would hit days like that. So that's an encouraging sign, gives us hope for the budget. The other piece we've experienced is more patients are being placed in an observation status out of the emergency room. And I know we've done a little education with Talia and Kim and others that just because the average census is 35 doesn't mean there are only 35 patients in the hospital. There are typically on any given day 15 to 20 patients who are in a real hospital bed in an observation status waiting for conclusion of and a physician's order to officially admit or discharge that patient. Those are typically short stays, but they occupy just as much resource as the inpatient in the bed next to them. The other driver from our hospital and most hospitals is emergency room visits. And while we saw a significant decline in the inpatient volume, our ER visits have been relatively stable. 2/3 or more of our admits come from that line. And so we're actually predicting a small increase in emergency room visits, and I'm counting on that to drive some of our inpatient volume. That also feeds the Meharry entity and their teaching programs as well, and the services that they supply at the hospital as well. Our clinic volume has been relatively steady. Year over year, not growing significantly, and certainly when there are physicians, I think Meharry had a few defections post a hospital inpatient closure announcement. We're working cooperatively to try to backfill some of those spots, and whether it be orthopedics, general surgery, pulmonary care, and so forth. We're working on those together. The one area that we have seen a little bit of a decline this year is our OB, our deliveries. February was a particularly low month. We are forecasting next year a static obstetrical program. It is in our budget at a static level of about 330 deliveries in 2019. So if you would move on to the budget itself, a couple of things I would highlight. As I mentioned, a 12% growth in our average daily census. Total FTEs are up about 5, so from 529 to 534. That's really just the volume increase accounting for that very small increase in bodies. Our total charges would be rebounding from a projected $226 million up to $247. That includes a 5% across the board gross charge increase. Gross charges, not what we collect, but gross charges. And then our net revenue, we think, can hold steady at about 17.25% that we would collect. But as you can see, the net revenue number rises back up to basically a little above where it was in 2017, $42.7 million, versus our projected this year is just slightly below $39 million with the volume drop that we experienced after November. We are projecting in this budget for our public hospital supplemental pool from the state, our essential access, and our DISH dollars to be static at roughly $19 million. You can see the 4.2 above and the 15.8. Those are the two numbers we're expecting to be static year over year. If they grow, that would be fabulous, but at least we're projecting them to be static. Big, sort of a large increase that you'll note is our salary expense. Last year it was 37.1. This year, with the decline in volume and the fact that we lost quite a few salaried positions, just nurses that left for greener or safer pastures, stable workforce, that number dropped off $1.9 million year over year. We're projecting for it to rise $2.6 million, or about 7.5%. 3% increase for salary increases, and I know the metro departments do it a little bit differently, but I have to present this budget as we build it. So within that $2.6 million, there's roughly $3 million, 3% for salary increases July 1st, and then there's the much discussed at council and prior, we dropped it to $1.2 million for retention pay. It was 1.7, I think, when we talked about it at council 60 days ago, 45 days ago. Without the specter of the hospital inpatient closure June 30th of 2018 or 2019, we think that we can manage that number down a little bit, and so we've dropped it from 1.7 to 1.2 in this scenario. We've kept our benefit expenses basically flat with the salary dollars. The one that you'll see on here is contract labor. I think when we checked last night, we actually have 55 full-time contract or agency staff in the hospital today. And I think maybe at its low point 2 years ago, it might have been 501. Okay, well. And just for comparison, the average nurse rate at our hospital is about $30. The average contract rate for a nurse is $65 to $75. So if you take 50 of those and multiply it by $40 an hour difference times 2,000 hours, you see why that contract labor is a really important number for us to address. Mr. Mayor, thank you for some of the comments you've made that made our people feel more stable and secure in their role at the hospital, because we're going to use that in our marketing, and we think that we can make hay with that, hopefully reduce some of these contract labor positions and put them back into full-time staff in the hospital.
Now, that's also true with physician recruitment as well. So the stability is very critical, and the more we can do and say about the future of the hospital, the more efficient we're going to be able to run, especially as it relates to our labor costs.
And then in the supply line, the other significant increase really in the budget for 2019, it's up about $1.5 million for next year. We have a 3% general supply cost increase. Just the cost of medical supplies is on a 3 to 4% annual increase. Pharmacy is also in that number, and that, particularly in the oncology space, we see low teens to high teens year-over-year increases in pharmacy. I know you guys have a big health plan, and that's probably the one thing that's the hardest to control. When you have a significant line like oncology, it's even a bigger number. So we budgeted our pharmacy cost to increase 9% next year, not 3%. And those two items together account for that increase in the supply line. Contract services, that's just a 3% inflator on all the contract services provided at the hospital. And then in physician services, there's a pretty significant increase there of $1.1 million. There's a 3%, again, inflationary. The largest item in that difference is we've contracted, or at least we budgeted to contract with an outside entity to cover our critical care areas in the hospital. And the net increase in the cost of that contract is about $60,000 per month additional. The repair and maintenance line is really just a small increase as we're getting ready for Joint Commission. And then in the other line, you see about a $500,000 increase. $250,000 of that increase is specifically related to advertising for us to work on our brand and our image, and hopefully to encourage patients to, again, access the hospital, but also to encourage staff and physicians to consider joining the hospital and helping us in our efforts to take care of those who need the help the most. Metro indirect is our low cap, as you would, $3.6 million. It's static, and that's how it's budgeted. And then interest expense is dropping a little bit. That's just basically the amortization of the building lease. So the interest expense drops a little bit each year, and of course the principal payment goes up accordingly of the $4 million that we pay on the building each year. So all in, you can see if you drop to the bottom, $46.6 million. You also add in the $2.5 million for Bordeaux and Knowles. I'm sorry, that's the lease. The $2.35 million is the Bordeaux and Knowles legacy costs. And then we're also suggesting that we would pay down $1 million more of our accounts payable by the time we get to the end of next year. And that produces the $47.5 million ask, which compares to this year with the supplement of a $52.3 million city support. And then on the next page, these are just really explanations for some of the things that I just covered, but it's there in case you want to have that as a reference point. I'm here to answer any questions that you have. And by the way, I also have Bill Latham here. Yes. I was going to go operating budget first.
I'd say just go ahead and do the whole thing.
Okay.
Yeah.
Okay. So behind this, we have a capital budget. The totality of the capital budget, the requests were a little, I know Talia deals with the same, the requests were a little over $27 million. We went through a review process, dropped the number down to $4.7 million that we consider critical. On the first page, you see items in orange. That is actually my 4% 2018 request that I actually dropped off with Greg yesterday, right? So we can drop that out of this request if that gets funded. I just want to make sure I'm clear. I left it in because it wasn't clear at the time if it would be. Okay. I just want to make sure it's on here, but if that gets funded, then obviously these will drop off. That $523,000 will drop off. We have a couple of sort of what I would consider critical items to deal with. Our computer, our workstations on wheels, about $300,000. Some patient room beds, about $500,000. And while I'm talking here about in the budget with Ms. Vircher and Ms. Lomax O'Neill, we, over many years, the hospital has accumulated a rather large operating lease cost. which is funded indirectly by the city's subsidy. We're renting hospital beds for $400 a month that cost about $8,000 to purchase, and I don't think that's a wise spend of money when we could purchase them outright. Same with pumps in the hospital. They basically have a 22 to 24-month payback. If the capital is made available, certainly I think it could be put to better use, could drop the subsidy by about $250,000 to $400,000 a year. Of course, it requires capital to get there. But I mention those because those are important just from a financial standpoint, trying to be a good steward of the dollars that the city provides to the hospital. Most of the others, a lot of them are maintenance. The lease that we have with Meharry for the hospital building requires that the hospital is responsible for all maintenance and upkeep, whether it's roof, parking garage, mechanicals, and so forth. So we do have to keep the building up on our own. It's not the responsibility of the lessor. A couple of, significant items. As I said, the pumps are $870,000. That's multiple pumps in each room throughout the hospital. Again, that's a 22 to 24-month payback. Would make a significant difference in our operating costs. And then the only other really significant dollars are two imaging items, $280,000 for our ED RAD room, and one update for an R&F room in the X-ray department, and then a $200,000, $195,000 item for our pharmacy distributing cabinets to expand the coverage in a couple of areas in the hospital, anesthesia and some other spaces where we don't have that capability today, but we do have it in other parts of the hospital. So we're just trying to put the same standard of care in every nook and cranny of the hospital, whether you're there for GI, OR, or you're there in the critical care unit. No, questions. I'm sorry.
With that,
Ready for questions now?
Yes.
yes, sir.
All right. Usually I let them go first, but I'm going to go first this time.
All right.
And start by saying that our city has a very long commitment to providing a safety net for healthcare in the community. That will not change this year. Additionally, the city has a decades-long history of supporting Meharry Medical College, and that will not change this year either. So that is the starting point for everything else that's going to be said today. At the same time, we have an obligation on behalf of the taxpayers to make sure that every penny that's sent for this purpose is well spent, and that there's a clarity of purpose where both Meharry Medical College and Metro Nashville General Hospital are aligned as they proceed. So let me just jump straight to the budget for a second and just to the spreadsheet here.
Sure.
And just make sure. I think the viewing public and everybody looking at it needs to have some clarity. Last year, essentially, there was $52 million that the city sent to subsidize the operation of General Hospital, correct?
Or will by the end of the fiscal year.
Will by the end of the year.
Correct.
And it looks, when you look at the spreadsheet, it looks like we would be sending less in the coming year, that you're asking for less in the coming year, 47-point-something million. Is that right? That's what
Correct.
It looks like. But last year, there was an AP carry forward of $8.5 million that was paid down. This year, there's only $1 million in the budget for AP carry down. Is that right?
That's correct.
So essentially, in terms of amount of money, of funds available for operation of the hospital, excluding pay down of AP, there would be more money available to the hospital to operate in the coming year. Is that right?
That's correct, Mr. Mayor.
And it's not clear to me exactly how much it is, but it's more than $2.5 million, maybe even more than that. Is that right?
Correct. Yes, that's correct.
Do you have a sense of precisely how much additional funds would be available to the hospital at $47 million?
It looks like it's, I mean, I'm just doing the quick math myself, it's about $2.6 million net.
Right. Above and beyond that, there is other items identified in the assumptions that could result in additional revenue to the hospital. For example, the retention payments might be lower than budgeted based on the city's commitment to the continued operation of the hospital.
Could be.
And to the extent that Meharry and General could increase the number of admissions to the OB ward, or its operation were to change, there could be additional money for other operations in the hospital as well. Is that right?
General capacity.
Right.
Bed capacity. Yeah.
Right. There could be other things available there, right?
Right.
And the professional services agreement is still it's not negotiated in its final form.
It has not changed, let's put it.
It's in the process.
It's in the
We
process.
anticipate giving it to Meharry the end of this week or the beginning of next week. Our board meets next Thursday, so they'll have a chance to review it before that, and then we'll move. So we would anticipate that within the next 2 weeks.
And so that's something that's subject to negotiation.
Absolutely.
Right, and so hopefully there'd be some agreement there that would both be positive for Meharry and positive for the operation of the hospital.
Agreed.
Yes.
Is that correct?
Yes.
Yes.
I don't mean to treat this like the cross-examination, but I just think everybody needs to be. This is one of those areas that's subject to some contention, so I just want to make sure everybody, both here and outside of this room, understand where we're headed. Because I think that's an important part of making sure that this money is well spent, and is to make sure that everybody does understand each other. And I think, as Ms. O'Neill stated, there is a $500,000 plus request for high priority capital needs, and that the council will receive that in a 4% request tomorrow, and that I'm supportive of doing that, and hope
Thank
the council
you.
will
Thank you.
approve that as well.
Thank you.
So obviously, this is an important area for the city to make progress on, and to have a sense of consistency, a sense of certainty about both how much it's going to cost and what sort of services are going to be provided. I know that there are fluctuations just in the economy that will have an impact on how many people need General Hospital. I know that the expansion of Medicaid, if our state were to do that, would have a significant impact on the operation of the hospital, and I hope that we see that happen, because it would be good for our city if that did happen.
Yep,
There are tens of thousands of people in our city who would be eligible for expanded Medicaid if the state would go ahead and do that, and I wish they would. But above and beyond that, know that there is a commitment to the hospital, but know that the commitment is going to come with intense expectations, that the parties involved work together, that they find a way to align on a purpose and pursue it with openness and transparency. And with that, if either of you have any additional questions,
Go ahead, Tony.
I don't have any questions. I would not be doing what I needed to do if I didn't thank Bruce, because he has been inundated with questions from the finance department since he arrived.
That's all right.
And
I don't take offense.
and he has just really worked with us with a welcoming spirit, and
Thank you.
it has been a very good relationship.
Thank you. I feel the same way.
With my department and the staff, and thank you.
Thank you, Talia.
I think the last thing I would add here, and you touched on this briefly, but I just want to make sure it's clear for everybody who doesn't have this document in front of them. The $500,000, roughly $500,000 in capital investment, does that set you up to deal with the Joint Commission review successfully, hopefully?
Yeah, those items were pulled out specifically as they were the higher priority ones.
Okay.
Obviously, there are others because of the total 4.7 ask, but that does put us in a good position. And one thing the Joint Commission will want to see is, are you making a commitment? So even those things that haven't quite yet been spent, they want to see where you've got resources allocated within your capital budget to get there. So it gives us a good start.
Absolutely.
Okay. That's all I have.
One thing I would add that I should have stated at the very beginning, Dr. Hildreth is here from Meharry today, and I guess I would say my office is open for y'all to come and meet together with me. I think that would be an important step in terms of aligning our purpose, and we still have. I think I can probably fit you in around 6:30, either in the a.m. or in the p.m. But I do think, obviously there's been lots of ups and downs and things that have happened in the press over the preceding months. Not everything has to happen there. And, I'd love for an opportunity for us all to sit down and talk together at some point in time.
We will certainly take you up on that.
We'll call Patrick.
Thank you. Thank you all very much.
Thank you very much, man. Thank you.